Welcome to our webinar titled Sweet Syndrome and MDS, What is the Connection? Thank you for joining us. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I'd like to recognize the generous support of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, and Takeda Oncology, as well as the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in and hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing your question or comment, hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our specialists cannot answer any specific questions related to your personal health care. Today's specialists are Dr. Aditi Shastri and Dr. Rose Snyder. Dr. Shastri is an associate professor of oncology in the Division of Hematological Malignancies and Bone Marrow Transplant at Montefiore Medical Center and Albert Einstein College of Medicine. Dr. Rose Snyder is a fellow with MB.B.S in Brooklyn, New York. Welcome, Dr. Shastri, and welcome, Dr. Snyder. Thank you for joining us today.
Thank you so much, Lee, for that very kind introduction. I just wanted to first double check that you guys can hear me clearly. Just hold the thumbs up if you can hear me.
You're
okay.
Good.
Okay, very good. All right, so can we get started with our presentation? I can share the slides.
Yes, thank you, Dr. Shastri.
Okay, so I'm going to share my screen. Okay, and then I'm going to make it up. I'm sorry, just bear with me. I just have one little technical difficulty. Oops. Okay. Let me just do that again. Okay, and I'm going to hit screen share. Yeah, I'm so sorry. As soon as I hit screen share, it somehow, my screen's blanking out.
That's okay, Dr. Shastri. I'll go ahead and share my screen and you can just tell me to advance the slides. If you could unshare and I'll take care of it. Just give me about 10 seconds.
Okay, why don't we do that? I'm so sorry for the trouble.
No problem. That's why we always have a backup option. Thanks to everybody for the patience.
Yeah, thank you. Yeah, I think that might just work better because for some reason my computer's blanking out.
Are you able to see my screen now, Dr. Shastri?
Yes.
Okay, great.
Give me one. Okay, great. So, hang on. Let me see here. Yes, I can see your screen. I'm just going to enlarge it. Okay, perfect. So welcome everybody, and thank you very much for this opportunity to speak with you today about Sweet Syndrome and MDS, and to understand a little bit about the biology of the disease and you know, how these two are connected, and what we could possibly do to treat these two diseases when they occur simultaneously. So next slide. So these are just my disclosures, but my slides are free of any commercial bias that has to do with any of these roles in research funding and consultancy. Next slide. Next slide.
One minute, Dr. Shastri.
Okay, hold on just a moment.
Okay, no problem. Okay, I'm sorry, I'm having some issues with the slides. I'm getting very small thumbnails. Okay, all right. So anyway, myelodysplastic syndromes, as you all very well know, I'm just going to do like a quick introduction. It is really a hematologic malignancy, which is characterized by bone marrow failure. And when we see this bone marrow failure, a result of this is the accompanying cytopenias. We see anemia, thrombocytopenia, low blood cell counts that we call neutropenia. And along with this, we have a very dysplastic looking bone marrow biopsy. 1/3 of patients with MDS overall have a tendency to progress to an even more aggressive hematologic malignancy called acute myeloid leukemia. Although the overall incidence that is recorded in registries such as the SEER registry appears to be low, if you look at actual claim-based registries, there is a higher incidence of myelodysplastic syndrome in the United States than we see in tumor registries. Next slide.
Just 1 minute, Dr. Shastri.
Sure, no problem. Do you want me to try to screen share one more time?
Yes, why don't we try that one more time, doctor? I'm not sure what's happening.
Yeah, no problem. You know, I'm just trying to think of why this. Yeah, just give me a second. I'm going to try to do the screen share again. You know what, perhaps I'm having some issue with my slide share view, but what I'm going to do is I'm just going to make the actual thumbnail really large so we can see it properly. Yeah, I apologize for that. Is this better? Now can people see the slide?
Yes.
Okay, all right. Oops. I don't know what happened. It stopped. Okay, all right. Let me just try again. Yeah, I apologize. I haven't really had this computer issue before, so I'm just gonna advance to where we were. Okay, so we were at this slide. So just a quickly epidemiology of MDS. Like we said, it seems to be a rare disease, but as claims-based registries are recording the data, it is becoming more and more common. In patients that are, obviously it's a disease of the older age group. So in people that are older, we expect to see this more. So age 60 and above, there's a much higher incidence of the disease than in younger age groups. So we use a few ways to kind of figure out how severe the disease is. And some of the ways that we do it is by some prognostic systems. The International Prognostic Scoring System is the most common tool that we use for risk stratifying MDS. I'm not going to go into great details because really the talk is about Sweet Syndrome and we lost some time, but it would suffice to say that the more your score is on the IPSS, the more aggressive a person's disease is. So bone marrow, we look at the bone marrow blasts, the chromosomes, cytopenias, while we build up the score for this prognostic tool. We also have a more complex prognostics tool called the revised IPSS MDS cytogenetic scoring system, where we also incorporate cytogenetics more rigorously than in addition to other clinical risk factors. And why this actually matters is because patients that have a very low or low IPSS score, this is without treatment, have an overall median survival that is better than patients that have low or very low IPSS by the survival by the risk category. So it's very important to actually prognosticate very well in MDS, and we also decide therapies accordingly. So how do we really diagnose MDS? So the most common presentation, as everyone knows, is cytopenias. We look at the peripheral blood, a bone marrow aspirate, and biopsy is always typically done, and cytogenetic studies are very important. And the diagnosis obviously does require demonstrating that there is dysplasia, that is, there is one or more of the cell lines look abnormal on the bone marrow biopsy and the counts are low. So this is just a picture of the bone marrow biopsy, which just shows you a few cells that are stem cells, which will mature eventually into mature cells. But as you can see here, some of them look a little strange and weird. This is a cell that has a nucleus that's kind of broken up. So, and this looks like it's sort of going the same route. So you do see some very abnormal looking cells that we call, that's what we mean by dysplastic looking cells when we see the bone marrow biopsy. So I just want to touch on the genomics of MDS very quickly. So as we can see, there's multiple different mutations that patients with MDS might have, and some of you might have been told by your physician about the mutations that you may harbor. And just keep in mind that these mutations could occur in normal people too. It's when the mutations occur with low blood counts that we call this MDS. So what are these mutations? So we see mutations in epigenetic regulators, which are, most commonly TET2, ASXL1, DNMT3A, EZH2. This mutation here, the IDH1 and 2 mutation, will become important as we will talk in relation to Sweet syndrome. We have, again, mutations in the splicing machinery, so in SF3B1, U2AF1, and these other mutations. There's mutations affecting the differentiation in cells, and you may also see mutations that affect the proliferation. So going forward. All right, so I just wanted to go through a few treatment landmarks in MDS. So this, very early on in the 1970s was when we discovered that abnormal chromosomes play a role in leukemia. The IPSS that I just showed you was something that physicians came up to prognosticate the disease in the 1990s. We had the approval for azacitidine in 2004. The deletion 5q- syndrome was also discovered around the same time. And as we went ahead, 3 years down the lane, we had another approval of a drug, decitabine, and then we had the approval of lenalidomide for treating the 5q- MDS. However, since 2005, we've really had a very dry period in drug development for MDS. And very recently, we've gotten some good news, which is the drug luspatercept, or Reblozyl, was recently FDA approved last year for treating patients with a very specific type of MDS, which is a refractory anemia with the ring sideroblasts. And then just in the spring of this year, we had an oral drug approved for MDS, which is an oral decitabine with a cytidine deaminase inhibitor. So I think we are now ushering in a hopefully new era where we should see more and more drug approvals for the treatment of MDS. So what is Sweet syndrome? Sweet syndrome was actually first described in 1964 and also goes by the name of acute febrile neutrophilic dermatosis. That's a really long name, so I think Sweet syndrome, that sticks with me better. And it's also named for the person that actually discovered the skin manifestation. It's not extremely common, but it is a rare inflammatory disease that we see by, that is characterized by these abrupt appearances of painful edematous, erythematous papules, plaques, or nodules. I know that the words sound, it's a very long sentence, but I'm going to explain as we look at the pictures. It can mostly involves the skin, but it can involve multiple internal organs such as the eyes, the musculoskeletal system, as well as some other organs as well. Typically, we see 3 types of Sweet syndrome. There's a classical Sweet syndrome, which does sometimes occur by itself or accompanies some autoimmune conditions. We have malignancy-associated Sweet syndrome, which is where MDS comes in. And this is the part where MDS is associated with Sweet syndrome, and then drug-induced Sweet syndrome. And this is important to talk about, as I'll tell you. There are, patients with MDS and AML can experience drug-induced Sweet syndrome too, and including patients with aplastic anemia, because one of the most offending agents for this is GCSF. So the granulocyte colony stimulating factor. So malignancy-associated Sweet. So about a quarter of patients with Sweet syndrome will have an associated malignancy. Sometimes the malignancy is diagnosed before the Sweets, and in many times the Sweets might be a clue that someone might have an underlying cancer. The hematologic malignancies like MDS and AML are much more common and accompany Sweet syndrome more commonly compared to solid tumors. And acute myeloid leukemia accounts for about 22% of all the cases of malignancy-associated Sweets. MDS has also been highly associated with malignancy-associated Sweet syndrome. There's a very specific subtype of Sweets called the histiocytoid variant, which is more highly associated with MDS. And this is a little harder to treat than the regular Sweet syndrome. The pathophysiology up until the early 2010s, 15s is not really well known, and there aren't very well established guidelines regarding the treatment of Sweet syndrome. As I told you all, and this is very important to make a note of, GCSF is associated with Sweet syndrome. So, it's a very common growth factor, which some of you might have received, that people get right after any chemotherapy that can suppress your counts severely. However, this can be associated with developing a skin rash and Sweet syndrome. So it's something good to keep at the back of your head. I'm going to try to explain now what I meant by erythematous, edematous. So this is a patient who has Sweets and MDS. And this is the specific type of Sweets called the histiocytoid variant. And what we can see here is that this patient has very reddish, purplish looking blotches that are raised from the skin a little bit. So it's almost like, it has a little bit of a velvety appearance. So this is what we see more commonly in MDS. However, you may just see it as like nodules or a rash, and I'm going to show you some pictures of that as well. This is more common for patients with MDS. And then when you do a skin biopsy, you do see that there is a lot of inflammatory cells there. So what do we mean by inflammatory cells? We see lymphocytes, we see cells that are, typically the scavengers. So histiocytic cells or dendritic cells, we see a lot more of these cells. So how do we actually treat malignancy-associated Sweet syndrome? Steroids actually work marvelously for treating Sweet syndrome, and most patients can have a good amount of relief with just maybe one course of prednisone. So the recommended dose is really 1 milligram per kilogram per day, which could be given as a single morning dose. We can also try, in cases where it keeps coming back or it becomes more severe, we could also do a much higher dose of methylprednisone, which is a more potent steroid, over a few hours every day for 3 to 5 days. Typically, we never give such high doses of steroids as a very high dose, because steroids, as you know, although they work very well in multiple diseases, including COVID-19, as we're seeing, they do have a lot of side effects. So we typically don't give extremely high doses of steroids for a long period of time. And then there are other drugs such as colchicine, cyclosporin, which are considered to be immunomodulators that we can use. Patients that I have treated have also said they have actually gotten some good relief from Lugol solution and potassium iodide, which is applied to the areas. So this is something also to keep in mind. Metronidazole, which is typically an antibacterial, antiparasitic drug, antibiotic, has also been used and is helpful in patients that have underlying inflammatory bowel disease like Crohn's disease or ulcerative colitis. And then in very extreme cases, tumor necrosis factor inhibitors or antagonists such as etanercept, infliximab, or thalidomide could be used and have been shown to be effective. Now, why do people get Sweet syndrome? This is something that has been an active area of research, and an active area of research for myself and Dr. Snyder as well, who is on the webinar with me. And what we do feel and have shown is that there is a connection with this mutation called the IDH mutation in MDS and AML. So some patients, about 10% of patients with MDS and AML will have the IDH1 mutation, and about 10% of patients might have an IDH2 mutation. So the IDH proteins are very important enzymes which are involved in many different cellular processes, and there are drugs which target these proteins. So we have IDH1 and IDH2 inhibitors that are FDA approved for the treatment of relapsed refractory MDS and AML. We have an IDH2 inhibitor called enacetinib, which is FDA approved for treating older patients as a frontline treatment, that are not fit for induction therapy for those that have acute myeloid leukemia. Now, this is just a little diagrammatic information on what the IDH enzymes do. So for those that are science nerds here, including myself, you know, we love these enzymes and these diagrams. And what these two enzymes actually do is they catalyze important enzymatic reactions that are important for the cell so that it doesn't run out of oxygen and experience what we call hypoxia. However, when these enzymes are mutated, there is increase in the level of what we call a metabolite, an oncometabolite. So something that's promoting carcinogenesis, this oncometabolite called 2-hydroxybutyrate. And this drug actually then, once this metabolite is increased, it induces some epigenetic changes in the cell which impair cellular differentiation and can contribute to the MDS and AML developing. Now what we found, and I'm going to demonstrate to you through this case, is we've treated a couple of patients at our center that have had MDS, AML, and Sweet syndrome, and also had an IDH mutation. So this was a patient that we had treated not too long ago, who actually presented to us with multiple lesions. So as you can see, his lesions look quite different from the other patient that I showed you. They are raised and erythematous, but not quite so purple and red and blotchy. So they are more under the skin. So it's more like what we call subcutaneous and the typical histiocytoid variant that we see with MDS. So he had disease that affected mostly his extremities. And as you can imagine, these lesions on the dorsal part of his hand were very painful. And this is basically what we found when we did a skin biopsy. So he had Sweet syndrome. We saw this infiltration of multiple immune cells. And this large cell that we can see here with many nuclei is called a histiocyte. So this gives us a clue that this patient has a histiocytoid variant of MDS. And then when we biopsied multiple sites of his body, including the skin, the bone marrow, as well as, you know, we did receive some tissue from the lungs because the patient had a pulmonary procedure, we found all these immune cells were staining for the IDH mutation by immunohistochemistry. So this gave us a clue that these patients might have the IDH mutation, which could be related to their Sweets. So what did we actually, so this is again the bone marrow. I just want to show you the bone marrow, which is looks like MDS. You know, this is a very, very large megakaryocyte, which is the cell that ultimately bears platelets. And when they look sort of just round and, you know, they're not really budding, they do look abnormal. So what we see here is like an abnormal looking megakaryocyte. This is the bone marrow aspirate showing many cells that have vacuoles in them, nucleoli. So overall kind of abnormal, suggesting that the patient has MDS. So how did we actually treat our patients? So the patients that we treated here, we did give them oral prednisone or oral steroids, and we did see a rapid improvement in the symptoms with steroid therapy. It is also very important, as I pointed out, to also diagnose and treat the MDS. So I highly recommend that the treatment of the MDS should go hand in hand with treating the skin condition, because the skin manifestations might actually get worse if we wait. So it's good to start treatment. And in this case, we used azacitidine or Vidaza. And I really cannot stress enough that we have to have multiple doctors involved because this is really what's best for our patients. So we need to have a dermatology expert or a dermatologist and an oncologist following patients closely for treating those, especially that have Sweet Syndrome with MDS. So we highly advocate a multidisciplinary approach. So just wanted to break away a bit to talk about how we, just how do we tailor therapy for MDS for the patients that are having MDS and Sweet Syndrome. So like I told you prior, we do risk categorize the patients. We look at the comorbidities. Do we need to manage any of them? Like, does someone have uncontrolled diabetes, high blood pressure that could get in the way of their treatment? These things need to be controlled as well. We manage their symptoms. Are they having really low blood counts and fatigue? Do they need a blood transfusion? And then the other issue is, how easy is it for them to tolerate a particular drug? Obviously, a patient that is living in a rural area or far away from their cancer center may have a different preference than someone that lives nearby, or, depends. So geography also does play a role in, what sort of drugs we prescribe patients. So for low risk MDS, and again, I won't delve into this, but I'm just going to mention the names because, should always be thinking about what options are available to you. So of course, transfusion support is very important. Growth factors are very important. Keep in mind though that GCSF can cause Sweet Syndrome as well. Lenalidomide or Revlimid is an excellent treatment option for patients who have the chromosomal abnormality where they have the 5q chromosome that's deleted, so the 5q deletion syndrome. Azacitidine can be an option for low-risk MDS for patients that are not tolerating any other drugs. We do use abbreviated schedules and lower doses. Luspatercept is a drug which is very recently approved just last year for treating patients that have refractory anemia and MDS, and then clinical trials are always an option. So always ask your doctor if you are a candidate for a clinical trial. It may not be necessary that you sign up for it. It's totally voluntary, but it's always good to have more options. For high-risk MDS, azacitidine and decitabine are really the mainstays of therapy. If an allogeneic bone marrow transplant is on the cards, then this is something that your doctors will obviously guide you through the process, and the whole team will be, it's a multidisciplinary team again that will be working very closely with you to get you to the transplant. And then again, in especially high-risk MDS, the clinical trial options are very important to explore. So like I said, bone marrow transplant is a curative option for patients with high-risk MDS, and always talk to your doctor about clinical trials and other options that you might have available to you. I just want to summarize here, just to kind of highlight some important points we talked about. So MDS, as we know, is characterized by cytopenias, bone marrow failure, and a third of all patients with MDS could progress to acute myeloid leukemia. The hypomethylating agents like 5-azacitidine and decitabine are very important drugs. They are the mainstay of therapy in high-risk MDS. Luspatercept and Revlimid or lenalidomide are important drugs in some patients with low-risk MDS that could give a very profound response. So it's always good to look it up, ask about it. Sweet Syndrome is an inflammatory condition that mostly affects the skin, but can affect internal organs as well. It is highly associated with hematologic malignancies, particularly MDS and AML. Histiocytoid sweets is much more common in MDS compared to the other variants. There are multiple lesions, as I showed you a couple of pictures. Some of them could be quite painful, especially if they're large and under the skin, so subcutaneous. Steroids are really the important mainstay of therapy. We have found that Sweet syndrome can be associated with the presence of an IDH mutation. However, IDH inhibitors, although they are on the market, are not still approved for treating Sweet syndrome and MDS. So probably this is an area of ongoing research that we need to take forward so there are more therapeutic options available to patients. And I cannot stress enough that a multidisciplinary approach is very important. So just to tell you a little bit about us, so I'm at the Montefiore Medical Center and Albert Einstein College of Medicine in the Bronx, New York. We are an MDS center for excellence. And the two physicians that see patients with MDS are myself and Dr. Amit Verma. We have very good support in the clinic with wonderful NPs and physician assistants that work with us, and a fantastic research team that is also offering many cutting-edge clinical trials. We also, like I said, we have to have a multidisciplinary approach. I have an amazing oncodermatologist who works with us at Montefiore, and her name is Dr. Beth McClellan. I want to put a plug in for her to say that oncodermatologists are actually rare, and I don't know how many there are in the country. So if anybody is suffering from any problems that they want a quick opinion on, or they want maybe to send her some pictures that she could give you an expert opinion, please feel free to share it with me, and I'm happy to help you however I can. Or if you would want to see her, she has multiple locations in New York, in the Bronx and Scarsdale. And this is just, I do post a lot of information on Twitter for patients with MDS and AML on new drug approvals and new studies. This is my email. As I said, please feel free to email me with any queries if you have. And I highly welcome that. Or if you want to get in touch with our oncodermatologist. The AMDS International Foundation website is a valuable resource, as is NCCN. And that's about it. That's the end of my talk, and I'm going to stop the share here. And we could get to some questions.
Thank you very much, Dr. Shastri, and Dr. Snyder will go ahead and take a few questions. What comes first, Sweet syndrome or MDS?
That's a really good question. And I would say that it could be either. It could be either. However, given that Sweet syndrome has such a dramatic presentation, where you can have these red papules all over your skin, it could be the first sign of developing a hematologic malignancy like MDS or AML. So if you do notice, if somebody does notice something on their skin, especially something that affects all their skin, on their torso, on their hands and legs, they should definitely follow up to get blood counts and checked as well.
Hi, everyone. I just want to reiterate what Dr. Shastri said in answering the question, that from my research, we had two patients at Montefiore with this IDH mutation in both their skin lesions and in their MDS. And both patients also presented first with the skin lesions. And in reviewing the literature, it also seems like the skin lesions will be noticed first, and it could be actually up to like a year. So patients can come in saying that they've been having these recurrent painful rashes that come and go. Their dermatologist might give them prednisone for it. And then it's only later that you'll notice an anemia, and then they'll be diagnosed with MDS with the bone marrow biopsy. So it does seem to be, MDS could have been underlying for before that, but it seems like often it's the rash that's noticed first, and then the MDS is diagnosed after.
Is Sweet syndrome more common among men or women?
Would you want to answer that, Rose?
From what I know, I don't think that there is a difference, but I'll.
Yeah, I support that. We have looked, after looking at some papers, you know, it does not seem like there is a particular gender predisposition. It's more associated, malignancy associated sweets is more associated with the underlying malignancy. And even with classical sweets or drug associated sweets, we don't see any gender predisposition.
With
There's a question here in the Q&A. Do you think I should?
Yep, we'll get to that one. Regarding with the sweets for the drug induced, have you found that once the treatment is stopped, the sweet syndrome will resolve itself?
So, you know, I would recommend that, like I said, we treat both at the same time. So when you are, so we do treat with short courses of steroids while we're initiating chemotherapy or while the patients are on treatment. Sometimes, you know, just by getting a good dose of treatment like Vidaza or decitabine, the sweet syndrome can be controlled if the underlying malignancy is well controlled. So it's possible, it's very closely tied into the underlying disease.
Thank you. Is there a risk that the skin lesions can become infected, being that infection is always a concern for MDS patients?
Yeah, so that's a very good question. Again, the risk of this actually getting infected is quite low because typically these lesions are small. They're not very large. They don't undergo necrosis. So, and then there's not too much skin breakdown that we see with it. So the chance of them getting infected are relatively low. It's more the appearance of it and the discomfort they cause just because of how many lesions a person could develop and the fact that it could get under the skin, which is particularly painful.
Thank you. One of the questions that we have is, if you're going to have a bone marrow transplant, what are the tests you should cover to get the most out of the biopsy?
Okay, thank you so much for that question. So for the bone marrow, so when if you're a candidate to get a bone marrow transplant, I'm assuming you're asking about the bone marrow biopsy. I'm going to answer to that is it's very important to actually, in addition to just getting the biopsy and the aspirate, to have your doctor send out what we call a next generation sequencing or a mutation panel. It's very important to know what risk category someone is in. Are they high risk? Do they have certain different, certain mutations? Because the choice of chemotherapy and the conditioning regimen that we use for the transplant could change depending on that. And the other important test I would say you should get is cytogenetics. So you have to have your chromosomes also evaluated. These are important tests to do from the bone marrow biopsy. In addition to this, the bone marrow transplant coordinators may also ask you for a cheek swab. So they could do what you call an HLA type so that they can select an appropriate donor for you.
And to tag on to that, we have a question: what percentage of patients survive a bone marrow transplant?
Okay, so this is a pretty loaded question, I would say. Thank you for your question. Yeah, so, again, like I said, so this is literally, like Lay said, tag teaming off the previous question, because risk prognostication is very important. So patients that have developed a second malignancy, for example, if the MDS or AML is a second cancer, not the first cancer, and it happened within 2 years of the first cancer, we call it a therapy-related disease. Or patients that have certain deleterious mutations like the P53 mutation. So people that have some of these risk factors are at a higher risk of relapse even after the bone marrow transplant. However, I have to say that bone marrow transplant, obviously it's not a procedure without risk. There are associated risks which are associated with the side effects from the chemotherapy, infectious complications, and then the risk of disease relapse, the risk of the procedure causing morbidity in the form of graft versus host disease. There are a lot of different things, but I have to say also that modern medicine is catching up with a lot of these things, and our risk of, and the way in which we give chemotherapy, the way in which we treat infections has improved a lot in the past decade. So each patient has an individual risk, which is really hard to box into like a category to say what percentage will survive. But it's a procedure which is a curative option, and I think the risk of survival should be discussed individually between you and your physician.
If you are an MDS patient and you've also been diagnosed with Sweet Syndrome and you have a bone marrow transplant, will the Sweet Syndrome resolve itself once the donor cells take over and your MDS is now resolved as well?
Do you want to answer that question, Rose?
Can try.
Yeah, sure.
So we do see sometimes that when patients have the Sweet Syndrome and the MDS at the same time, even though they require some prednisone, you do need to treat the underlying MDS in order to treat the Sweet Syndrome. So like I said before, patients will come in with Sweet Syndrome before they have the MDS diagnosis. So Sweet Syndrome will respond to prednisone, but will always come back. And these patients will come back, they'll say, I keep getting these lumps that are painful. And then in the end, they're diagnosed with MDS. And in the end, sometimes we see that the treatment with MDS will help stop the recurrence of the Sweet Syndrome. So I would say that if you are able to treat the MDS with a transplant, it could help. We can't say for sure, but it could help the Sweet Syndrome because you are treating underlying disease.
Yeah. So I agree. I'm pretty optimistic that, the transplant should help the Sweet Syndrome, because at the end of the day, it is an immune reaction to some cells, which, some of them might be cancerous that have infiltrated the area. And typically the bone marrow transplant induces a pretty robust immune response against the tumor cells. So one situation could be that you could have a flare for a short while before it gets better, but over time it should definitely get better with a bone marrow transplant.
Our next question reads, I've been diagnosed with low-grade MDS, 3% blast, and have been taking Aranesp every 3 weeks. I occasionally have lumps that have been diagnosed as Sweet Syndrome. Is this normal for low-grade MDS? They're currently taking 0.75 milligrams of dexamethasone every other day.
Okay. So, thank you for sharing. Thank you for sharing your history. What I would say is that, having Sweet Syndrome and the way that you're describing it with the lumps under your skin is pretty common, can be common with low-grade MDS as you're describing. If you think that the disease keeps coming back and it's really bothering you very much, you should talk to your doctor about doing a short course of pulsed steroids. You're taking a pretty low dose. 0.75 milligrams is a very low dose. So perhaps 4 or 5 days of a slightly higher dose of steroid may give you a longer period of relief from the skin symptoms. The other question really is, okay. It's not coming back, he says. It seems to be under control. Okay, well, if it's not coming back, maybe just stay put on it. I wouldn't do anything different. I would just treat the MDS. The other question is, is Aranesp controlling your MDS well? I'm assuming you have low levels of erythropoietin, which is why the doctor is giving you Aranesp. But if you notice any change, like if you see that you're starting to need blood transfusions if you didn't need them before, or you need more frequent transfusions, it might be worthwhile to check your erythropoietin levels again to see if perhaps you might have become refractory to the RNS. Even in that case, there, like I said, there are a few options available for low-risk MDS treatment like Revlimid, which does work in patients that don't have the deletion 5q as well, luspatercept, low-dose Vidaza. So these are, there are a few options. I wouldn't say many, but a few options for those that eventually fail RNS.
Have you found any of the current MDS treatments that potentially make the Sweet syndrome worse for patients?
So that's an interesting question. There are 1 or 2 case reports of, some treatments, like particularly azacitidine, which might have made it worse, but I think this is unsubstantiated, if you ask me. I don't think there are any treatments per se that make the Sweet syndrome worse. I don't think, except for, like I said, if you're getting GCSF as a growth factor, for supporting your neutrophils, you could see a flare of Sweet syndrome, along with certain other antifungal drugs. Some antibiotics can be the culprit as well. So if you do see it, it's good for the doctor to review your drug list to make sure it's not a drug that's the culprit or a treatment.
Is there a particular age group that seems to be more affected by the Sweet syndrome and the MDS connection? Is there any cases of children being diagnosed with Sweet syndrome and MDS?
Do you want to answer that question?
I'm not aware of an age predisposition, and I am not aware of it being in pediatrics.
So I will say that's true. I don't think there's an age predilection. It's similar to the age where we see the peak in patients having MDS, which is typically age 60 and above. Children can have Sweet syndrome, but it would be more in the category of classical sweets. It's much rarer in children, and we don't typically see malignancy-induced sweets or drug-induced sweets as much in little kids or pediatrics.
Well, thank you very much. That seems that's all of the questions that we have for today. So thank you so much, Dr. Snyder and Dr. Shastri, for sharing your time and your expertise with all of us today on this very interesting topic. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes our program. Thank you again, Dr. Snyder and Dr. Shastri.
It's our pleasure, and like I said, please feel free to reach out to us if you have any questions with regard to MDS or aplastic anemia. I treat many patients with aplastic anemia as well, or anything related to Sweet syndrome. So thank you very much. I'm sorry for the disruption with the PowerPoint, but I hope everybody was able to see the slides.
Thank you.
Thank you. Bye-bye.
Bye-bye.